elaborate onto this as, one second, sorry, it's being recorded, so I'll just say it as continue. Okay, yeah. So as we go along, I'll elaborate on this and we are going to go in detail of much of it. So just before we head start to the actual topic of early warning score, I wanted to start a little bit with cardiac arrest. I'm sure some of us have heard about cardiac arrest. Some of us have experienced cardiac arrest, seen cardiac arrest. And some of you probably might have seen patients who collapse in front of you or at home, your family, relatives. Why am I talking about this here? Because I just want you to have an idea what we are going to head towards to. So we all know that patients who come to our hospital who are unwell, that's why they come to the hospital. And once they're in the hospital, some of these cardiac arrest, not some of it, actually, majority of our cardiac arrest which happens in the hospital is preceded with some signs of deterioration. And once we all know that the cardiac arrest happens, the survival after the cardiac arrest or returning back to their normal life is very little. Any cardiac arrest rhythms, which could be PE arrest or VFVT arrest, any patients who sustain a cardiac arrest, once they're returning back to their normal life, it's very little, or they survive is less than 20%, I would say around 13 to 13.5%. And also any patient who have this cardiac arrest or who go into cardiac arrest in hospital, I'm particularly talking about patients who are in hospital, they will give you some sort of warning signs before they go into this cardiac arrest. So especially for patients who get admitted to hospitals in the evening, in the weekends. So when they give you some warnings, we fail to pick up on it. And that's when the cardiac arrest happens. So when a patient who presents to hospital who is acutely unwell, what we need is a fast and efficient response to it. You need to identify who is sick, who is unwell in your care. So what is important? Important part is the time. You need to, time is of the essence, and I can't emphasize it enough, because a patient who is acutely deteriorating, early identification of deterioration, who is deteriorating, you need to identify that quick. Then timely response, respond to what you have seen. By whom? A competent person, somebody who knows what they're doing. It could be whoever it is, a person who knows to deal with it. That is the actual content or the matter of it. You need to identify a patient who comes to the hospital, who is the sickest, what is happening, who is deteriorating, and respond to it. There's no point in you identify Mr. John is becoming unwell and you haven't done anything about it. You need to respond with timely manner, very quickly. And by whom? With a competent person. So a large proportion of patients who suffer cardiac arrest in hospital, who have, this is a study which I'm talking about, who have routine observations being taken, and they have, and we have studied about it, and we showed they had a change in vital signs, which have not been picked up early enough, which has not been sorted out early enough, has been ended up in cardiac arrest. So this is a study which was done by Hillman, which says a large proportion of patients who suffer cardio-respiratory arrest in hospital have recognizable changes in routine observations during the preceding 24 hours, including their changes in vital signs or level of consciousness and oxygenation. And if you haven't dealt with it in time, that is when the arrest happens, or that is when the deterioration happens. So who is at risk, and how do we know which patient is the sickest patient or the more unwell patient in your care, in your department? Is there a system we can use to identify the person who is deteriorating? Or you might have 20 patients with 2 nurses. I do not know how your staffing ratio works there, but I'm sure there is more patients than the nurses anyway. So there should be a system which help you to understand, a simple system, it's a very simple system, should be able to identify or understand who is the sick patient among my group. And you should be able to respond to them much quicker than any other patients. So this is the system which we are going to talk about, because every second count. When I say every, I deal with critically unwell patients and acutely deteriorating patients every single day in my life. And I can't emphasize enough, when a patient who is deteriorating, every second matters to their life. The more, the quicker a septic patient, a patient who is in a VT rhythm or VF rhythm, you need to act on it immediately. Identify, you will save them, you will prevent them going into the cardiac arrest or into the onto mortality. So we have a small quick question in here. I'll hand over to Rajendra for it. I can't hear you. I think
unmute, please.
Okay.
Thank you, Jasmin. So, okay, I'm going to share the link for the quiz. So you can see in the chat box now. Can everybody see?
Yeah.
Yeah.
Okay.
Not yet.
So you have 25 seconds to complete this one now, and the timing starts now.
Rajendra, it's not appeared on the chat box.
Okay.
Yes,
Please click onto this link, and you have 25 seconds to complete this. Okay, I have got only 2 response. We'll move on. Okay. Yeah. So the right answer is early detection, timely response, and competency. So 2 candidates answered, which is right. Thank you. I'll hand over back to Jasmin.
Great. Okay. Can you see me back now? Am I back onto my screen?
Back to screen sharing.
Okay.
Yeah.
Thank you for those 2 students who have answered it. I'm glad it was right. Yeah. that's important. Even if it was one person, but they understood it. I know it sounds very, very difficult to be in the web and to do this way, but we'll get there. I'm sure we'll get there.
Jasmin, can I just remind the students, kindly listen to Jasmin's presentation. You will get the answer for your pre-course evaluation questions as well as your live polling questions as well. If you listen to the Jasmin's presentation, you will have the answers in the slides itself. So best of luck for the next one. Carry on, Jasmin.
Okay, I'm trying to go to the next screen.
Yeah.
Okay. So now I just to go back to the few sentences I've said. Why have I given you so much introduction about early warning score? Because in order for you to understand how important early warning scoring is, very simple. It's a very simple tool which you use every single day in your career, in your nursing career, in your hospital. We just put it up in a nice format, and that is it. There's nothing more in there added on to it. So it is so important in a patient's life to know how a patient deteriorates, or to find out who is deteriorating. It's very important. That is why I have given you a small introduction of the importance of cardiac arrest, the importance of time. So what is EWS or NEWS? In England, we call it as NEWS, which is National Early Warning Score. This was created by the Royal College of Physicians in 2012 to standardize the process of recording and responding to changes in acutely ill patients. It's a very simple scoring system where you have allocated a point to each of your physiological parameters. I'm going to go in depth about this one by one. So if you hear me saying NEWS, don't get worried. It's NEWS and EWS is the same. So we had quite a lot of, we had some inquiry happened in England about patient deaths. And during that process, it has been identified that there was a delay in identifying certain patients' deterioration. And that is why those patients have deteriorated and arrested and died, or had a cardiac arrest or deterioration and had the mortality. So that is why they have initiated a system called EWS, and to find out how we can prevent or how we can improve. And this is being now accepted nationally in England, in every hospital in England, along with the ambulance. So anyone can use it, it doesn't matter, because we all speak in one language. That is what it means. When I talk about a sick patient, when I say, Swami, my patient is actually new score of 5, he understands what that means. Or if I say to my or the ambulance crew is telling me, look, we are bringing a patient who is the new score of 10, I understand what that means. Everyone understands. We all speak in one simple language. That is what the beauty of actually early warning score. So we are going back to it. It's a tool which will improve. This is a tool. You're not going to do anything extra in there. This is a tool which will improve the detection and response to the clinical deterioration. When I say that, if I say my patient have new score of 1, and my colleague is saying that, oh, Mr. John have new score of 10, I understand who should I go and prioritize, who is the first patient whom I should be seeing. So this will actually increase the patient safety and improve their outcomes. And it will help you identify the sickest patient in your unit or in your area and who should you be attending to. So the elements of EWS, if you can see my screen, you can understand this is all every single day you do in your day-to-day life. What are the elements of EWS? What do you have it in there? It is your respiratory rate, your oxygen saturation, systolic blood pressure. We use a systolic blood pressure to score. Pulse rate, your level of consciousness or patient with new confusion. Temperature. I'm going to go in detail with every one of them as we go along it. So these are the 6 elements of EWS. So yet again, we have respiratory rate, saturation, your systolic blood pressure, pulse rate, level of consciousness, or we will say new confusion. Why do I say new confusion is we have patients who is probably 90-year-old grandma who is probably demented, or who have Parkinson's, or who have chronic confusion. That is not what is being counted. What we count is a new confusion. A man who is 40-year-old coming to your unit who has been okay, you spoke to him and who has been fine, but now he began to be confused. It is a warning, it is an alarm, there is something happening in his body. So that is why we say it as new confusion. Temperature, if a patient who is having high temperature, low temperature. So all these 6 parameters, we allocated a score. We'll go to the chart and then I will show you how that works. So please remember, these are, I'm sure every hospital, every one of you as nurses, you would be monitoring patients' vital signs. And these are the vital signs you will be monitoring and you will be recording it. You do this every day. But the only thing added in EWS is every one of these scores abnormalities, we gave them a number. If the respiratory rate above 28, it score you 3. If the systolic blood pressure below 80, it score you 3. Or the pulse rate is between 110 or 110 to 120, we score them 1 or 2. And you, at the end of your observation, you add these numbers together. That will give you your new score. It's so simple. And when a patient who is needing inspired oxygen, if you are giving additional oxygen, any patient who gets an extra oxygen or you give oxygen, you have a score which is 2 allocated it. I hope I'm making sense to you guys. So it's so simple. Every day you do this in your ward, you record your observations, which is your standard observations, and every one of these observations has given a score. As you finish your observation, you just add the scores together. That will give you what is the new score for that patient. If all the observations are normal, for an example, if your respiratory rate is 15, your oxygen saturation is 96%, your systolic blood pressure is 120/80, or your heart rate is within the limit, which is 70, your scores are 0. So you will be telling me, oh, Jasmin John is scoring new 0. I'm happy, I'm fine, because I know this patient is stable. Or you will be telling me, and it saves a lot of time, and you don't need it to, there is no rocket science behind it. It's so simple. At the same way, if you tell me, oh, Tom is scoring now new 6, it's an immediate, as a practitioner, it's an immediate alert to my brain. Oh, there is a new 6 of a patient. That means there are some parameters which is abnormal to this patient. Either he is tachycardic, or he is hypotensive, or he is desaturating, or tachypneic. So it is so simple. So these are, please remember, these are the elements of EWS, which is every single day you do in your workplace, which is your respiratory rate, oxygen saturation, your systolic blood pressure, pulse rate, level of consciousness, or new confusion. Is your patient alert? This is what we are asking. Temperature, and does this patient require an additional oxygen? So how does news work? So we are going to go back to each one of them as we go along. So first, what do? You measure. You go to your patient, you take the observations, then you record it, then you calculate what is the score, and you identify who is your sickest patient. Very, very simple. So we go, we measure the patient's observations, you document it, and you just calculate what is the score and see if you have 10 patients, one is the news of 0, and the other patient is the news of 4, or the other patient is news of 10. You will identify who is the sickest patient among your group. So this is how, if you can see my screen now, this is how a news chart look like. It's very simple, it's color coded, it's easy to understand. As you can see, the colors, white, we're all happy. White, any number which fall in white is peaceful, we are happy, it's normal. And you can see there is, I don't know how much clear is my screen for you. If you can see, the next one is yellow. Yellow is like warning. That is a warning. If any number fall into yellow, give you a warning. Orange, an alarm. Yes, yeah, there is something we are not happy. Red is danger, as we all know. The color red is something which you give it for danger. So it's so simple. Even if you don't read the number, if you can see a patient's observation falling into red, it's very important even for clinicians, the doctors who don't have time. They might have many patients to see. You come pick up the chart, have a look. Oh, okay, all the observations are in the white. Fair, I know my patient is stable, or their observations are stable. Look at the observations which fall into red, which indicates you, oh, there is something which is concerning. So it's so simple. The chart is designed as very simple, which white means any numbers which fall into those white columns means those observations are stable. Yellow will give you a warning, an alarm. Orange and red means dangerous. This patient's observations are really worrying. So in the chart, it's a so simple tool we use, a simple chart we can use. In the top of the chart, you can see you have an option to write your patient's name, their date of birth, your identification details. If I put it in a simple term, those are your identification details. You put it in there. Then comes, you can write the date and the time of the observations that you've been taken. And in the middle of the chart, in the middle of the chart, you can see a score is allocated. I don't know whether, Swami, can everybody see this? If you think the chart can be seen a bit more?
Jasmin, can you enlarge? You can come out of the big screen, presentation screen, and just enlarge it.
Okay, let me see if I can do that.
Just press the exit button.
Escape button.
Let me just check. Escape button.
While you're trying to do that, I apologize. While you're trying, so Jasmin, you carry on. Yeah. I do apologize to all the students who were unable to get onto the chat box. Apparently, it was disabled, and that's why you were unable to answer the quiz questions, which were kind of surprising that we only saw 2 answers. So it looks like it's been fixed now. Kindly try that again. So we should be back on now. The chat box is live now. If you have any issues, just type on the live box itself, chat box, or you can type on the Facebook live. So we get the message.
Can you see my screen now, which has been zoomed a bit more?
No, I think you have to start sharing again.
Do you want me to zoom and screen it?
You can see now?
Yes, we can.
Yeah, better. Okay.
Yeah.
So as I said to you at the beginning of, I'm sorry, we just having this little bit of interruptions in between because I need to go on. If I zoom it a bit more, you can see it better, that's why. So the beginning of the chart, you can see that there is an option where you will write your patient's name, your date of birth, or your identification details, date of admission. You can design your own chart with whatever the top, the identification detail you wanted to add on for your hospital or your institution. And on my left side, you can say it's written as respirations, oxygen scale, all the 6 parameters which I was talking to you about. It is being given on your chart. So you're going to do the observation on your patient and you take a respiratory rate. And your patient's respiratory rate is 17. You are going to put a small dot on the time wherever you are going to take the observation, whatever the time. If you are doing at 9 o'clock, you will make it as 9 o'clock and you put a small dot there to say the observation or the respiratory rate is between 15 to 17. And you can see it scored nothing. It scored 0. There is no, it's fallen to the white and it scores 0. Whereas if you take the observation and you saw your patient's respiratory rate is 28, you can say it's fall into the red and it's straight away scoring number 3. So what do? Is you're taking the respiration and you count it and you record it. You are writing it in the number what you got it, 28 or 25, 24. And you leave it there and you see that there is a number which is allocated to that observation which is being done. Then you go to the oxygen saturation. What is the saturation for this patient? If the saturation is more than 96, you will put a dot where the saturation is. We normally put it as a dot, so it's good to join in. So you can see the trend of the patient's observation in your chart very easily. So record your saturation and you put a dot. And you see if the saturation is more than 96, it's fall into white, the score is 0. Or if your patient saturation is less than 91, it scores them automatically number 3. So you have taken the respiratory rate, you have taken the saturation, and you can see just below the saturation, there is something called scale 2. Scale 2 is applicable only to patients, all our hypercapnic patients, patients who require a bit of high level of carbon dioxide to breathe, for an example, COPD patients, or our long-term lung patients, lung history patients, respiratory history patients, who are falling to the category of scale 2. So you should not be using, why? Because it's an additional safety system put it in by the second revision of our new chart in England. They have added scale 2 in our chart just to be on more safe side, because you don't want to deliver higher level of oxygen to our hypercapnic patients, our COPD patients. So you will use that only under the instruction of your doctors. If your doctors come for the water run and they say that this is a hypercapnic patient, we will use scale 2, we will go to the chart of scale 2. Otherwise, we will use the normal scale 1, which is your oxygen saturation level. Next comes, there is a question asking you air or oxygen. Is this patient on room air or are you giving oxygen? As I said to you, if you are providing supplementary oxygen to any patient, because normally you don't need, you and me, we are breathing from room air. If any person who is requiring additional oxygen, it tells you there is something wrong, right? They are unwell. So it's simple as that. So if they are requiring additional oxygen, that will automatically score you number 2. I'm going to sum up. This sounds a lot of information. This is not this because I'm explaining to you it. When we sum up, you will understand. It takes hardly 30 seconds to 1 minute to do the whole process. Okay. So your patient is scoring oxygen. You will put where the oxygen and that will automatically going to score you number 2. And you can write what device it is. Is it through nasal cannula? Is it through face mask oxygen? Is the patient on an IV, CPAP, whatever? So you can write the device which you are delivering oxygen through. The next option is the blood pressure. As I said to you, we will use systolic blood pressure. I know diastolic blood pressure have impact on your anaphylactic patient and stuff like that, but we use a systolic blood pressure for the patient. So for an example, if your patient's blood pressure is 120 over 70, you score it, you put a note there to the up to here, it's 120 over 70. 120 is a normal blood pressure, so systolic blood pressure, it doesn't score you anything, it's 0. If your patient's blood pressure is now sitting 90 over 50, you can see it's straight away falling into the red. Your observation, you will document into the red column, which is scoring you 3 immediately. So that is an alarm that tells you patient is hypotensive. There is something happening. It's an alarm. It's dangerous. Here comes next your heart rate. It again, simple. If your patient's heart rate is 80, 70, you can see you will put a dot and it scored nothing. There is 0. Whereas if your patient's heart rate is 130 or 131, it scored 3. The patient's heart rate is 100, your pulse rate is 100. It scored you, because the patient is tachycardic, it scored you 1. And comes the consciousness level, which I said to you about. Is the patient alert or is the patient have a confusion? It's so simple. And I'll talk to you through the assessment. How would you assess this? I'll talk to you through as we go along. If the patient is alert, we are fine, we are happy, we're not worried, it's okay, patient is alert. So you will score them 0. If the patient is having confusion, and which is, I let you know, this is new confusion. I'm not talking about a 95-year-old grandmother or somebody who is with the history of confusion or dementia. We don't score them. That's their normality. But if a 50-year-old man or a 60-year-old man who is admitted to the hospital with an abdominal pain, and now you are seeing, you saw this man in the morning, he was fine, he was talking to you, but after 2 hours of your shift, you're seeing your patient is slightly confused, is not making sense. That is a warning. That is telling you something dangerous happening. So a new confusion straight away score you 3. It's a risk. And if the patient is not responding, it's only you have to call and say, John, wake up. When you say the patient is waking up, that is when he is conscious. That will straight away score you 3 because it is a warning. It's very serious. If the patient is only responding to pain, for an example, you need to give it a previous pain. That's what we do in here to inflict pain. We used to do sternal massage, but not anymore. But if the patient is only responding to pain stimuli, it score you 3. If the patient is unresponsive, you were talking to John, now you went to give the medication, you are seeing him unresponsive, no response. It straight away score you 3. It's dangerous. GCS is 3 out of 50. Why do we use this scale? Is because it will make nurses' life much more easier. I don't want to ask all my nurses to score GCS for they might have 20 patients and 1 nurse. So in England, we always use AZVPU, which is very quick and easy. Say hello to your patient. Patient is saying hello back to you. Your patient is alert. So simple. The patient is confused. If the patient is only woken up with your voice, if the patient is only awake when you inflict pain, or if the patient is unresponsive, they straight away score 3. Next comes temperature. What is the body temperature? Are they spiking temperature? Are they pyrexial? Are they having high temperature? The temperature above, a bit blurry in there, the temperature above 39.1, which basically going to score them straight away 2. A temperature of 36 or 37, which score them 0, which is normal. And hypothermia, the patient who is with temperature below your 36 or 35, imagine your temperature is 35.3 or 35. It's straight away, it's hypothermia, it straight away score you 3. So this is a simple chart. And at the end of that, after you write your temperature, you can see they will ask you to write the total new score. I'll take you back to the chart again. For example, if my patient John, we'll call my patient as John, John's respiratory rate was 28. You can see it will score straight away 3. John is requiring oxygen to maintain his saturation, but he is maintaining saturation more than 96. But he
Jasmin,
requires oxygen. Yeah. Yes.
sorry, can you enlarge the screen a bit more if you can?
Okay, let me see if I can go a bit more here. Better?
No, a bit. No, reduce it a bit more. Reduce it left side.
Okay.
Press the minus button. Yeah, that's better.
Yeah.
Yeah,
Better?
that's a bit better. Yeah, yeah.
Okay. So, okay, let me just go back to it. So if John is having respiratory rate of 28, you can see anything above 25 is scoring 3. So you will straight away put your observation there and you score them 3. He's scoring 3. His saturation is normal. He's saturating 98%, but he is requiring oxygen. He needs 2 liters of oxygen, or he needs 5 liters of oxygen. That is scoring them 2. So straight away we know John's new score is now 5. And his heart rate is normal, his blood pressure is normal, his temperature is normal. But his new score is 3, because why would he be tachypneic? Why do he need oxygen? So that is a concern. And this is a man who was talking to you, who was absolutely fine. All of a sudden, he becomes tachypneic. So as an intelligent nurse, you now know he's scoring 3, or he's scoring 5 because he's requiring oxygen. He's becoming tachypneic. You would pick up the phone, you call your chief, or you have a senior nurse, or you have, or whoever is your escalation portal. You would tell them, my patient is now scoring 5. Can you come and review this patient? Or he looks a bit unwell to me. So there is a small column which give you the area where you will actually write down what is the new score. So you write all the observation. At the end, you just needed to add up the scores, but you got it and you write it there. If you're telling me the score of 2, I'm okay, all right. John seems to be slightly unwell, but new score of 2. So everyone understand when someone says, it's a one common language we say. I call my consultant and say, look, Dr. John, here I had Tom, who is the patient, who is my patient. I'm just calling him as a patient. I say, my new score was 3 yesterday, but now his new score is gone to 7. I have a concern. And the consultant understands, my doctor understands, okay, he had a new score of 4, now becomes 7. That means this patient is deteriorating. Very simple, something is happening. Or you can say, within last 2 hours of observation, I have seen the news is getting worse. So that is alarming you that this patient is deteriorating. So if I take you back to the next slide, which will show you how a completed news chart will look like, if you can see here. I'm sorry. Thank you. If you can see here, this is how a news chart will look. So it's so simple. It's up to your organization. You can use color pens or black pen, blue pen, whatever. It doesn't matter. There is nothing that. So as I said to you, the respiratory rate, you can see from the chart itself, it's split up. You can see the normal respiratory rate went up to tachypnea. It came down, it settled. So it gives you a trend how this patient was for the last 12 hours. You don't even need to read anything. That chart will clearly show you where were the observations were. You can see the oxygen level was dropping down. You can see the blood pressure always stayed okay. It was normal. Patient became tachycardic in between. So this is just an example of, I've just copied from the website, that just to say, this is how a completed news chart will look at you, like that's a 24-hour chart, or your 5 days chart. You can use how often your observations are being done. So this is just to show you how a chart will be looking like. So there is a small quiz coming up for you guys. I'll give it to Rajendra just to do that.
Okay, can I encourage all the students to check your chat box now? This is the second quiz question.
Okay, if you could just look at your chat box, guys, and see there is a small quick question coming up for you to have a look at it. So we can see. I hope you can see it. Yeah.
Okay, I'm going to post the second question now. Is it visible now in the chat
Yes.
box?
Yes.
Okay. Okay, students, you have 25 seconds now to complete this. Here we go.
Did we give little less time for them? 25 seconds? They have to be extra sporty.
Can we extend it?
I can, yeah.
Yeah, go on, extend it. Pause.
Maybe give them a bit more time probably, because I know that I think may take their time, right?
Reset it, reset.
25 more seconds extra.
The question.
He's
Only one
asking where
question.
is the, he know the
Question did not come.
Polizar is asking where is the question, he's asking.
Who, sorry?
No, question did not come.
No, it's in the link,
We have to check the chat box, sir.
chat box.
Are we asking this question of how to do the new score, is it? Is that the question?
If the patient heart rate is on 110, what would be the new score?
New score.
Because you know, they should see actually the screen of because they're not going to remember what is the score for 110, isn't it? Because do you understand
Okay.
what I'm saying?
Okay, can we display it on the Jasmin?
Yeah.
Can you share the screen?
Yeah,
One second.
I'll share it. Give them the question, let them have it in their hands, and okay, you're trying to do that. There we go.
Okay, so I'll stop sharing screen.
Uh-huh.
Okay.
Jasmin, can you share your screen?
All right, I'll share the screen actually. Don't worry, Rajendra, I'll share the screen.
Okay, yeah.
Okay, so the question, guys, was, it is, if a patient's heart rate or pulse rate is 110 per minute, what would be the new score? That is the question. That was the question is given to you. So I'm showing you a chart here, which you can see. I want you to look at this. This is a small card. Nobody is expecting you to remember what it will score for what number. You don't need to. It is all, and I don't think anyone, even I can't remember it. I'm using for the last so many years. I can't remember the number. So it's easy. So it will all be documented in your chart. You just needed to look at it. So the question Rajendra given you was, what is the score if the patient's heart rate or pulse rate is 110 per minute? So you can follow my cursor here. The patient's heart rate is between 110 or 111 to 130. That will score you 2. If the patient's pulse rate is 91 to 110, that is going to score 1. It's so simple. Please don't get worried that, oh my God, how am I going to remember this number? You don't need to remember none of this, okay? You don't need, we're not expecting you to remember it, and you will not remember it, and you don't need to remember it, okay? So it's so simple. So I hope you have had the question, and I gave you the answer too. So I want you to all pass the question which they have prepared, yeah? Can we okay? Have the question time finished?
Yeah.
Yeah.
Are we getting a poll from someone? Are we getting?
Yeah, 111 students has answered.
Cool. There we go.
That's good. Yeah. That's a great response compared to last two.
One was my vote too. One was my vote too.
Obviously, no.
Okay.
Who got it wrong? We know that. Yeah.
So okay, yeah, that is in the gray box.
Okay. Right,
Okay. So that's a good thing. So 61 students answered right out of 115 now.
Okay.
That's great.
So we will win. We are just started. It's a new process. We are getting through it. So
hand over back to Jasmin, please.
Okay. Thank you very much. So once again, guys, students, please don't worry about any of these numbers. It's so simple. You don't need to remember it. We have a chart or a little, this is like a little hand thing we will have in our hands, or it will be displayed in our watch, and it is already in your chart. So as you can see, respiratory rate below 8, score them 3. If a patient with a respiratory rate of 12 to 20, score is 0. If the respiratory rate is 21 to 24, that will be a score of 2. If your patient whose oxygen saturation level is less than 91, that will score straight away 3. If your patient's oxygen saturation is more than 96, score is 0. And if the patient needs any supplemental oxygen, it doesn't matter 1 liter or 50 liters. If you say yes, that is scoring 2. Temperature less than 35, that will score them 3. Temperature more than 39.1, which is scoring straight away 2. So it is very simple way to calculate. As long as you know to calculate 2 add 2 is 4 or 2 add 1 is 3, that is all you need to know. If you know that, you can do it. It is so simple. Heart rate less than 40, straight away it's bradycardia, you will score them 3. If the heart rate is more than 110, that score them 2. Patient is tachycardic. Level of consciousness, as you can see, is only 2 choices for you. If the patient is alert, we are happy, 0. If the patient is not alert, I don't mind whatever it is. It's confusion, it's verbal, this patient is only responding to pain, straight away 3, because it's a big one. Okay, so here comes the next. I'm going to give you a small clinical scenario. Okay, so there is a small clinical scenario which we have just set it up.
Jasmin, do you want to go on the full screen now on the PowerPoint?
Am I not in the full screen? Okay.
No, yeah, it's better. Yeah, that's better.
This is a case study. Mr. John is a 30-year-old young gentleman actually who is getting admitted to medical ward with complaints of cough, high body temperature. He is treated for chest infection. He does not have any other past medical history. And you as the nurse now doing the observations. His respiratory rate is 28 per minute. His oxygen saturation is 96, which he requires 8 liters of oxygen via face mask. His blood pressure is 133/70. His heart rate is 130 per minute. His temperature is 38.1. This guy is alert. This gentleman is John is alert. Okay, so let's go back to the question again. So here we have John, who is a young guy, who is 30-year-old, who is coming to hospital with cough, high body temperature. He's been diagnosed with chest infection / pneumonia. He has no other past medical history. His observations are his respiratory rate is 28, his saturation is 96 with 8 liters of oxygen. His blood pressure is 133/70. His heart rate is 130 per minute with temperature of 38.1, and he is alert. Could you all try, and I'll take you back to the news chart, could you all try and see whether you can score the John's new score now? So his respiratory rate was 28. So which straight away we know it's going to score him 3. His oxygen level was 96, which is scoring him 0. So that's fine. So far we have 3. He requires oxygen. He's on 8 liters of oxygen. Straight away he's scoring 2. So now we have the score of 5 already. And his blood pressure was 133 over, I can't remember the number, 133/70, which is okay, normal. I said to you, we are going for your systolic blood pressure. So 133 will fit in here, 133/70. So new score is 0. And he has his heart rate is 130, which he is tachycardic. So 111 to 130, he is scoring 2. So we already scored for respiratory rate 3, his oxygen 2, which is 5, and now his heart rate is 130, so he's tachycardic. His observation now is already 3 add 2 add 2, which is 6, and his temperature, I think he was pyroxyle, right? Yeah, his temperature is 38.1, which is scoring him 1 again. So we are now having the score of total 8. So you have respiratory rate score you 3, you have oxygen score you 2, and you have the heart rate score you 2, and you have 3 add 2 is 5, 5 add 2 is 7, and then you have your temperature, which is scoring you. I'm a bit struggling to remember my scenario with your screen. Your temperature is scoring you 1. So we know now John have new score of 8. And if I now call, I know John came, he was okay, he didn't need any oxygen. In the last hour I did the observation. He was coughing, he was slightly pyrexial, but he was maintaining his saturation of 96. But now he needed a bit of oxygen to maintain the saturation. So you can see your score from 5 will become 8. So I'm going to call my SHO or my consultant and say, look, John came into the A&E, his new score was 5. Now his new score have gone to 8. Immediately who understand news know, oh, this guy is deteriorating. His number is getting worse. Or you're going to call me to say that, look, I had the guy who is in this ward or medical ward. He have a new score of 3, but John is having a new score of 8. As a clinician, as a practitioner, immediately I'll be thinking, oh my God, okay, John is deteriorating. His new score is now 8. I need to act on it. It's so simple, it's very easy and effective way to understand who is the sickest patient in your unit. Also, how is your patient is moving towards you. And you are telling me now, John, as we know, John has scored, he is alert, so he didn't score anything. So John has news of 8. After 2 hours, you repeated the observation and you tell me that the new score is now fallen to 4. For an example, we didn't need any more oxygen. The saturation is maintaining without oxygen requirement. His respiratory rate is come down to 18. So the new score will drop down. And you tell me, oh, John's observation I have done last hour, it was 8 and now it's 4. What is it telling me? It's telling me indirectly that John is improving. Oh, I don't need to worry. His situation is getting better or his clinical condition is improving. It is so simple. That number, what you use, you can just say, Dr. Smith, see, I'm calling about John. John is having new score of 8. Now it is become 3. Are you happy with this? Or we'll say, okay, absolutely fine. It looks like he's working towards the right direction. So we'll continue the same treatment plan. Or if you tell me the new score was 2 and now it is 8, I'm alerted. I'm worried. We need to change what we need to do. Does this patient now need to be moved to high dependency area? Does he need more monitoring? Does he need to be intubated? Do we need to do something more? This is how you analyze the new score. It's so simple. Now, we have identified. So there's no point in you identify and you have done nothing about it. Okay? You identified something. You have assessed your new score. And we have a trigger score, trigger threshold, we will say. For an example, in my hospital, this is the chart we use. Any patient whose new score of 0, you don't need to go and because you have 20 other patients, you have many other clinical procedures to do. You might have wound dressing to do. You might have chest drain to change. You will have many things to do. So a patient who is scoring new 0, you will only do your routine observation. You just needed to do probably once in 12 hours. I don't know, depending on your institutional policy. Okay, you may need to do one set of observation every shift. If the new score of 1 to 4, there is an action plan. You need to increase the frequency of observation because you know this man, some parameters are not normal. So you will immediately have a plan. You inform your senior nurse in charge. If you are the new junior most nurse in the unit and you have done the observation, you have noticed your patient is scoring new score, inform your nurse in charge and say, look, this patient is actually scoring 4. Maybe increase the frequency of observation. Think, let me repeat the observation after 2 hours, after 4 hours. If you have new score 5 or more, or any 3 in 1 parameters, let me emphasize this. If the total score of 5 or any one, for example, John have all of the observations are normal, but his heart rate is 140. It's scoring him 3 in 1 parameter. He is tachycardic for some reason. Okay, you need to increase the monitoring frequency. Repeat the observation within half an hour, within 1 hour. That depends on your organizational policy. You can set up your own trigger score. When do you want your nurse to call you? This is what I tell my doctors. You tell me when you want to be alerted. Do you want me to alert when the new score of 5, or if you want me to be alert when the new score of 4? In England, we say new score of 5 or 3 in above in any one parameter, immediately you need to inform the senior nurse or the nurse in charge of your unit, or the primary team who are responsible. If this is a surgical team responsible for this patient, inform your surgical team and say, John is scoring news 5. And they will tell you what to do. They may say, okay, can you do an observation after 1 hour? Can you start some IV fluids? Or you can say, what is the parameter scoring the patient? Say the patient is hypotensive, systolic blood pressure is 80, then your team will say, okay, start some IV fluids, or there will be a plan. Total score of 7 or more, we all know that automatically fall into, that will automatically fall into red, which is telling you this patient needs continuous monitoring. This patient may now need to move to intensive care unit or your high dependency unit or an area where you have expert help. In here, they will call us. We as an critical care outreach team, we have to go and review every acutely unwell patient who scored 5 and above. So that is our threshold. So if my nurse call me and say, Jasmin, I have a patient who is actually scoring new 6. Can you come and review? We go and review and we assess and we'll say, okay, let's keep the patient in the ward. We will increase the observation every hours. Can you monitor this patient every hourly and see if the news is worse? If the news is worsening, we will impact on something. We'll make a decision. We may need to change the antibiotic. I may need to give extra fluids, depend on the condition, or if the patient may need a bit of CPAP support, we will decide. So there is a threshold. So we will assess the patient, we will record it, we will measure it, we calculate, and you have a response to it. You do something about what you have seen. If your new score is 7, you don't write it and you sit down and relax. No, you will call the relevant team, the doctors, escalate according to your trust policy or your organizational policy. And I always tell, because my students and my colleagues say, if the new score is going high for a patient who has been come for an example, an elective surgical procedure, always think, could it be sepsis? Because sepsis is a killer. We all know globally, so many patients who die because of sepsis. Immediately, just put it in your brain, is this patient septic? What is happening to this patient? Why is he become tachycardic now? Is he bleeding? What is this tachypnea is all about? Why is he developing a new chest infection? Think, is it sepsis? So we are going to summarize all of it just to say, you can see it's so simple. Every single day we do all these observations. It is only that one added thing is you allocate a score to each parameter. That is it. So why is it important? Because out of me as a critical care outreach nurse for the last, how many years, 7 to 8 years as an outreach specialist nurse, I have seen we prevent so many cardiac arrest. We prevent so many unwanted admission coming to intensive care unit, unexpected death, because you identify them early. As we said in the first PowerPoint, every patient who come to hospital, who get admitted in the hospital, vast majority of them will give you a warning before they go into cardiac arrest, before they go into heart attack. They will give you a warning. You would see them having a level of consciousness. They're becoming confused. They become tachycardic. They are hypotensive. They would give you a warning. And if you're doing the observation, you noticed your new score was 3. After 2 hours, you noticed your new score is 5. After 3 hours or another hour, you notice the new score has now become 10. You can see where this patient is heading towards to. This patient is actively deteriorating. If you haven't done anything about it for the next half an hour to 2 hours or whatever the time frame, this patient will definitely go into cardiac arrest. They will deteriorate, they will arrest, they will die. So EWS has a simple, anyone who knows to do an observation, even a healthcare who does understand. In England, we understand, everyone understands if new score of 5 means, oh, you don't need to remember what is it scoring you 5, but new score 5 means there is some abnormality in your observation. New score 0 means, oh, all the basic observations are stable for this patient. So it increases the safety of the patient, actually. And it's actually a patient safety initiative we had in here, which is now globally in US, in Australia, many other worldwide countries have adopted it and practicing it, and it is proven it is making a changes in people's life. And it's a universal means of communication. Now, if I tell from here, I don't know where Rajendra works in England or in Ireland, if I tell you, Rajendra, the patient's new score is 8, you do understand, oh yeah, patient shouldn't be scoring 8. You do understand there is some normal physiological parameters is not normal. There is some abnormality in this patient's clinical observations. Simple, I'm going from here to transfer a patient to another hospital. This is what I say, look, I'm coming with a patient with new score of 10. The other hospital, A&E, understand this is a sick patient who is coming to me. Or if I tell the ambulance crew, guys, I need an emergency transfer, could you come? This patient is new score of 13. They understand this is one of the sickest patient who they are going to transfer to somewhere. It's a universal means of communication. So it reduces the chance of mistakes. And it has a good predictive value of patient deterioration. And I say that if I see a patient's new score of 8, now that become 5, and the next hour you saw that it become 5, and it become 3, you know that, oh, okay, my patient is actually improving. Look like, oh, maybe in another 12 hours time, I can plan for a discharge for this patient, because all his physiological observations are getting normal. It reduces the number of unexpected cardiac arrest. It improves patient's outcome. Yet again, I can't emphasize to say that. Reducing, because I deal with cardiac arrest almost every single day. Once a patient, it's not a good scene to be involved in, to be honest with you. It's chaotic to deal with a cardiac arrest in a hospital setting. And you can see the survival is very little. You rather prevent your patient getting into cardiac arrest rather than treating at the point of cardiac arrest. It's so important that prevention, which we always say, isn't it? Prevention is better than cure, whatever. Yeah. So it will help you identify. You don't need to be an expert nurse to understand this. A junior nurse, a student nurse can understand new score of 0, okay, no problem, my patient's kind of okay. If new score of 5, there is some call, oh, okay, this patient's blood pressure might be heart rate. There's some abnormality. It is so simple for you to understand. Now, the exemptions of EWS, as we all know, there are 3 case scenarios we don't use EWS, which is in pregnancy, in children, and in patients with spinal cord injuries. Because pregnancy, you know the norm in pregnancy, we do have a different monitoring, which we'll call it as MUSE, which is maternal early warning score, and children we have PUSE, which is pediatric early warning score. I am not the expert on that. I talk about adult because I work in an adult side. The reason is because, you know, in pregnancy, their physiological normality is different. In a children, newborn baby, if you tell me heart rate of 120, which is okay. So they have a different early warning scoring chart, which has been used in England. So the exemptions of your EWS is pregnancy and children and in patients with spinal cord injuries. It is because their baseline normality is different from a normal adult. Now there is a small quiz coming up for you guys to be interactive. So I'll hand over to Rajendra here. Please listen to the question, or either you read out or say it in play.
Okay, welcome back to the most funding session now, quiz. Okay, I'm going to post the third link for the third quiz. Okay, students, you have 40 seconds to answer this question.
Rajendra, could it be better you can read out the question maybe as well?
Yeah, I'm sharing the screen, 1 second.
Yeah. Maybe you can just read it out. That may help them to.
Oh, sorry. No, actually, I can't go back to the screen because it shows the right answer from because I'm the admin.
Ah, okay, don't worry. I can actually.
Okay.
That's the question.
Question is that what are the 4 steps to remember during early warning score? So first one is measure, read, calculate, and identify. Second option is mark, record, and calibrate and identify. Measure, record, calculate, and identify.
So what do you do? What are the 4 steps in early warning scoring? Normally, what do you do with it? You will measure.
the
Just a
students
simple,
need to.
when you do the TPR, when you're doing in the real clinical setting, you are doing the TPR. In what process you do follow? Is the same process applicable to the news also?
Absolutely.
Yeah.
And this was something that was discussed just few slides before.
We don't put them in stress, okay? It's all right.
No, for them it will be a bit complicated question it is to
Yeah,
understand basic concept.
Yeah, absolutely. They do this every single day. You do measure it. You do record it. The only
When
thing
we
you
got
have
training,
to...
when we got training, this one, it took nearly 1 day to understand.
Yeah, and we are asking you to understand it in 10 seconds, in 50 seconds. It's very
Really
unfair,
impossible.
we know it, but we have no, I rather like to do this in a live session, in face-to-face. We can have more interaction in here, but unfortunately we can't, but no.
Okay, I think.
Jasmin, you think we can, we got another 20 minutes so then we can take some questions. Is that okay?
Yes, that's right. Yeah,
okay.
yeah.
I'm going to stop this.
I'm
going to stop this polling.
Yeah, that's right.
Okay. So 59 students answered right.
Good.
That's good.
That's very good. That's
very good. So now 60.
The hardest thing to remember it. So something
Yeah.
going right somewhere. Yeah.
Yeah, absolutely. 74%, nearly 75% student answered right. That's a great thing.
Very good.
Okay.
So you are
well
very
done, students.
attentive. I can see you are listening to me, which is good.
Okay, I hand out back to Jasmin.
Okay, perfect. Thank you. So we're ready. I'm trying to go back to my. Okay. So, sorry, excuse me. So we have now identified, you know, your patient's new score is 8, John is scoring 8. I'm just making it up, okay, for you to understand. How do we escalate? So you identified there is a problem. I know, I'm sure in your settings also, same as my settings, we don't have too many doctors. We only have few doctors to cover up the wards. So how do you escalate? The system we, oh God. 1 second, I don't know that I can. Okay. Let me go back to this. So how do you escalate? So the system we use is in the hospital, in England or in here, we use a system called ISBAR. It's just a short form. It's simple. S stands for situation, B stands for background, A stands for assessment, and R stands for recommendation. So what is this all about? This sounds like, again, and I made it as a rocket strategy, but it is not. It's so simple. How do you communicate with your team, your nurse, your colleagues? You always have to use a standardized way of communication. When I communicate about my patient, when I wanted to say, I've done a new score, I know my patient's new score is 8. Now I want to alert somebody. I want to call Dr. John or let's say Dr. Sam, who is actually busy in theater. But I want to let him know that my patient is unwell, he is scoring 8. I need to know how I'm going to communicate, how am I going to, I don't need to tell, I'm sure the doctor in the theater is busy. You don't want to know all my story. The patient had a visitor who came in 2 days before. You don't need to say any of that. What you need is the relevant information about your patient, which is called as SBAR. So S stands for situation, B stands for background, A stands for assessment, and R stands for recommendation. We are going to go in detail with this now. So what is SBAR? It is a very easy way to remember. It is a very simple framework we use to communicate between the teams. You can use this strategy to communicate between you and a physiotherapist, when you hand over between nurses handover, when you hand over your patient to the other shift, or when you hand over to the speech and language therapist, when you hand over the patient to your consultant. You can communicate to them in using the strategy called SBAR. You don't need to follow the same format. This is a format which we made it up. This is how we communicate about our patient to other team. So this will, why do we need this? Is because it will give you the standard prompt questions. You only need the relevant, precise information about the patient, and you can communicate effectively. You don't need to repeat the same thing what you have said. only relevant information. That is what I wanted to communicate to you. You only need, when a patient who is actively deteriorating, what is the other person or the doctor who wanted to know about is the relevant information about that patient. Okay, so this is a chart which we use in our hospital. We call it as ISBAR referral. And again, this looks very complicated, but if you learn to do this, this only take you 1 minute. And I'm going to go, I'm just slightly rushing because I know we don't have much time. We probably have only 20 minutes to remind. So how do we communicate? Using ISBAR. So I'm going to refer a patient to my colleague or my consultant. How do I say? You say first situation. Say, I'm Jasmin, doctor. Let's say our doctor is Sam. Sam, my name is Jasmin. I'm calling from surgical ward 2 or medical ward. I'm calling about John because his new score is 8. This is your situation. Does it sound difficult? No. You are a clever, intelligent nurse. I like my nurses to be all smart and intelligent. This is how you would communicate. You don't say, doctor, I don't know where I am calling. Doctor, this is what. No. Your information has to be precise. You would say, I'm Jasmin. I'm calling from surgical ward. I'm calling about Mr. John, who is actually with the new score of 8, new score of 5. Already the doctor will understand, or your consultant will understand. Okay, there is something happening with John. He has some physiological parameters which is not right, because you already said news is 8. Okay, background. What is the background information you talk about? As I said to you, I don't want you to tell Mr. John had a visitor came in yesterday, brought him some dal curry and chicken curry or some chapati. You don't need to say any of that. You would say the relevant information. This is John who came in with an abdominal pain, or John came into the hospital with cough and cold 2 days before, or 2nd of December. And he is with the history of, because the person who is sitting in the other end of your phone need to understand what you are talking. So you would say he have a background history of asthma, COPD, hypertension, cholesterol, whatever is his history, if you can remember. And say, the last 2 hours, his condition has changed. His new score was 5, now that become new 6. And now he doesn't look right. You can say, I have increased his oxygen. I started some fluid. That is your background. It's so simple. It's it's a structured format of communication. So you explain your situation, where you are, who you are, where you are calling from, why are you, who are you calling about, and what is wrong with this patient. Then going to an assessment, which is A. Quickly say, what is the problem? Say, look like he's more tachypnic now, or you can say he's unresponsive. If you're not sure of what is happening, you can say, look, I don't know. He doesn't look right. This patient does not look right. Say a quick assessment, which we follow ABCD assessment. In England, the systematic way of assessing acutely unwell patient is using ABCDE. Airway. How do you assess a patient's airway? 1 second. You only need 5 seconds. If you are a clever nurse, when you get, and I always tell my student nurses, my colleagues, the junior doctors who I work with, we will say, please, when you allocate to a patient, just go and say hello. Hello, Sam. How's John? You done your first assessment. It's done. If your patient can say hello back to you, they're protecting their airway. Simple as that. If they can talk, if they have a cough, just say. Breathing. What is the respiratory rate? What is the saturation of this patient? How is his heart rate? What is the blood pressure doing? What have you done about it? Is your patient alert? What is the temperature? How is his abdomen look? So assessment, you don't need to do. I don't think, I'm not expecting you as a junior nurse or a student nurse to give a thorough assessment on a patient. No, you just need to say that, look, I came and I reviewed this patient, or I have taken handover. John is unresponsive, or he is able to talk to me. The doctor will understand, okay, he is talking to you. That means he is protecting his airway. He can protect his airway. He is tachypney. You can say his respiratory rate is 28 with saturation of 90, and I've given some oxygen. His blood pressure is now sitting at 80/40, and his tachycardic. So it gives you a precise information. You don't need to say anything more than that. Just the precise information of your patient. And the exposure, you can say his abdomen looks more distended. He looks like he is in pain. Anything else clinical about this patient, you hand over in a systematic way. And your recommendation, you can say, look, I have given the oxygen, I have started the fluid. What time can you come and review this patient? Or do you want me to do anything about this patient? Do I have to put up a peri-arrest call or a cardiac arrest call? In England, we have a universal number, or we use 2222 as our cardiac arrest call. And I'm sure in India you have code blue or some emergency response team you have. Ask your team doctor, do I need to use the emergency team? Do I put out a code blue or cardiac arrest call? This format of communication is called ISBAR, which is a systematic way you present your patient. For an example now, I will hand over a patient to you. If I'm handing over a patient to you, this is how I will do. This is John. Imagine we have John here. Doctor, I'm Jasmin, or you can say my name is Jasmin. I'm calling from surgical ward 2. I'm calling about John, who is, because this, he is unwell. His new score is 8 or new score is 10. You've done your situation. Now you can say John has come to hospital 2 days before with a history of cold or cough. He's having a high temperature and he has past medical history of COPD. He's asthmatic. And for the last 2 hours, I'm seeing that his condition is being changed. He's becoming more tachypneic, he's cyanosed, and he looks really unwell. I've set the background. And he's able to talk to me, or he can cough, or hardly he can cough. He's unresponsive, or his respiratory rate is now 28, and his heart rate is now from 110, it went up to 130, and his blood pressure is 80/40. He doesn't look like he's beginning to be confused. He was okay talking to me last 2 hours before. Now he looks confused. He's not oriented to the time and place. And he's spiking temperature. Any other information, and his abdomen is getting distended, or he is actually very, very confused, fighting with us. These are your assessments. This is a very valuable piece of information you have given to your doctor or your senior team. And you can say, I started some IV fluids, I've started some oxygen. What do you want me to do? Can you come and review this patient? Or when do you come and review? Do you want me to do anything extra? Or you can document it, who you have escalated this to, who did you call, what you have done. This systematic way of response is called ISBAR referral. This is called as an ISBAR referral. This is how we refer our patient to the next team. When I hand over to my next colleague, when I finish my shift, I go home, I hand over my patient. This is what I will say. This is John with a new score of 10, who came in on 2 days before with a history of so-and-so, and this is his clinical condition at the moment. This is his observations are, and we have given antibiotics, we have started fluid, and he is now sitting with news of 5. My colleague will clearly understand what I have said. This is how I hand over my patient to my consultant, to my team doctor or my medical registrar. So he understands, we all understand, okay, John have this. Instead of you saying, oh, puffing around and, oh, I don't know, he came in that day. No, always communicate within your team in a structured manner. You need the relevant information, and that relevant information will save time, save you from making mistakes. So you pass the right information and the person in the other end can understand exactly what is happening. So a systematic way of communicating a patient is called ISBAR, which is situation, your background, you will say, your brief assessment, and your recommendation. I hope I made sense to you in here. Now, who are you escalating to? So we have identified, we have taken a set of observations, we have scored them, and you have recorded, you identified, you now need to, you know how to communicate this information, how to say this information to your team doctor or to your senior nurse. But who are you escalating to? Every hospital should have some sort of an emergency response team. As I said, in my hospital, we have CCOT, which is we are called Critical Care Outreach Team. I think in Australia, they have called med team, was medical emergency team, or you can have rapid response team, code blue team. So you need to have, and that is a safety net. We will call these teams are called safety net. Any deterioration, because as we know, a deteriorating patient, every second is important. You need to have a group of team who are ready to act on when a patient is deteriorating. So some form of emergency response team should exist to ensure the specialized timely care. I am not an expert on some of the aspects. The surgical registrar might not know how to deal with a cardiac arrest. So there should be an emergency team in every hospital, I believe, ideally. It doesn't matter which format. We have, as I said, we have critical care outreach team. We are 8 of our in our team. Any patient who go unwell in the ward or who are deteriorating, beginning to deteriorate, they will call us and let us know. So we know in surgical ward have 2 patients with new score of 8. I will know in medical ward there are 5 patients with a new score of 8. So you need to have a team in place to be aware of this deteriorating patient in the ward. So I'm just going to brief to ask you or to let you know what is news or why do we need news. News is simple. It's very simple scoring system. It is called as a track and trigger system. It will provide you with a continuous record of clinical condition throughout a patient journey. From the time your patient comes to the emergency department, your accident emergency, you will do a set of observation. I'm sure every one of us will do that. And you can see what was the news score that time. And after 2 days, you can look back and see, oh, okay, the patient came with the news of 2. Now the news is 0. It tells you that the patient is improving. You can see the patient came with news of 2. Now the news score of 10. You know the patient's clinical condition is deterioration. Trigger. So there should be a standardized way of assessing acute illness severity. As we use this news, you know the news as it goes high, the patient is more and more sick. That everyone understands in here. In England, it's national. Everyone understands when a patient's news score is 12, everybody knows that patient is very sick, unwell. And early warning scoring is designed for adults. This is, as I said to you, we have exemption. We don't use it in pediatric. We don't use it in maternity. They have different scoring system, which is called as news and PEWS, pediatric early warning scoring. And there are 6 physiological parameters which actually score the early warning score, which are again, we have our respiratory rate, saturation, your heart rate, your blood pressure, temperature, and level of consciousness. And we do score for oxygen, additional oxygen which we give. And every one score should be recorded in your observation chart. And all of those parameters adding together will give you your total news score for that patient. And once you have a news score, you should know who you should be escalating to. What is the news threshold? This mainly I say to the institutions because it is up to you as the organization to set when you want your nurses to call you, with what level of news score. Do you want to be called when the news score reaches to 3? Do you want to be called when the news score reaches to 4? Or do you want only to be alerted when the news score of 7? And you need to know what the nurses should do when the news score go high. For an example, with the news score of 7, you should be able to tell them, okay guys, now can you put this patient on the continuous cardiac monitor? Or can you call the emergency team to come and quickly review this patient? Or you should say, look, I will be coming to review this. So there should be a trigger threshold up to what you can bear. In my hospital, we take up to news score of 5. If news score of up to 5, the ward team will manage the patient. Whoever is the primary team, the ward doctors, the ward nurses will manage the patient. If the patient's news score go 5 and above or 3 in any one parameter, they would alert us. Then now as critical care team, we will go and review the patient, we assess them. So this is just a summary to say that recognition and response system should be part of standard clinical practice, and introducing a new system to optimize care of patients whose condition is deteriorating. It's actually no nurse can do it alone. No doctors can do it alone. It has to be the organization and the leadership to decide what safety net you want for your patient. Where would your patient, this is simple to introduce and it has been successful, and you need to set up when my patient needs to be alerted to me, or how do I want my patient to be in my care when they come under. So every hospital, this is our advice to say, every hospital should consider to set up a news committee and a news protocol, because we all do this actually. These observations, these are not something new, which we do every single day for every patient who comes to our care. So you give this code and have an emergency team in place to deal with this emergency. In that way, you will prevent any unexpected deterioration of your patient. I think there's another quiz coming up. Rajendra, up to you. Hello?
Yes, we can hear you.
Yeah, okay. Okay, students, this is the last question.
Well, just before Rajendra going, everyone should get this right, guys. Okay? I've said this now 20 times.
I'll give the answer before posting the question. Okay, guys. Okay, ready? Okay, so fourth question, which one of the following is not part of the 6 elements of early warning score? So you have to identify which is not part of the early warning score. So we have temperature, pulse rate, respiration, height and weight, systolic blood pressure, level of conscious or new confusion, and oxygen saturation. So which one you need to eliminate out of these? So please answer, and your time starts now. This time we are giving 40 seconds.
Yeah, it's not one. There are a couple of them. These guys are made you trick guys, so be very careful. Yeah. There are a couple of options which are wrong. You need to eliminate.
Jasmin, we minimize it to just one now.
Oh, really? Okay. Oh,
Yeah.
I haven't got that. Sorry. My apologies.
Yeah, no, we are not that harsh.
They're pretending to be good. Yeah. Go for it. So, which of the following is not part of the 6 elements of EWS? I believe it is straightforward. I'm expecting 100% here. There you go. What do we not need?
Okay, here we go. 3, 2, and 1. So 95 students answered, and 79% answered right, nearly 78 point.
Very good.
Yeah,
Absolutely. Well done to all.
Well
so
done,
you were listening to what I am talking. That sounds good, actually, to be honest with you. Yeah.
So still they're responding. I think if you give another, no,
Okay,
I think.
yeah, that's fine.
Yeah.
We are not running out of time, right? We are in time, I believe, right?
Almost,
yeah.
almost. Yeah.
Almost, yeah. We have another 10 minutes. Okay, that's fine. 5 minutes.
Okay. Okay, so shall we stop? 82% is right. Okay,
Yeah.
so
Oh, very good.
77%, 77 point, nearly 78%.
Okay, well done.
Okay, well done, students.
Very good.
And the right answer is height and weight,
Yeah,
which
we
need
don't
to be
need height
eliminated
and
straight
weight.
away from the early warning score system.
Yeah, we don't need height and weight. We're not going to measure those. Perfect. Okay.
Back to Jasmin.
Great. So we're just going to summarize the whole process what we have said now. Before I ask you for any questions, so I'm just going to brief. So you understand why I started with cardiac arrest, because as I said to you, it's easy. You prevent somebody going into acute deterioration. This is very important in clinical settings to identify who is sick in your group, because as a nurse, I'm sure you have so many patients to look after. Here we have 1 nurse for 6 patients, sometimes 1 nurse for 12 patients. That's a nurse-patient ratio in here, and every hospital do have. So you need to. This is an easy early warning scoring, an easy, simple, standard communication tool which you can use to assess and acutely assess it. And using this tool, as I said to you, you can use this anywhere. When you use your intra-hospital transfer, you want to take your patient from your intensive care unit to a CT scanner. You can tell, you can want them to say that we are coming with a patient from an emergency department or from intensive care unit with a news of 10. The person in the CT scan understand, okay, the patient who is coming is a sick patient. Or when you are transferring a patient from one hospital to another, you can call from your A&E and say, look, we are transferring a patient with news score of 12 to the next hospital. Or if you're transferring a hospital to hospital, any department within your, or you wanted to hand over a patient to a physiotherapist, you can tell them, you know, this patient's news is 4. So just be aware. So they know this patient has some physiological parameters which is abnormal. So it is a very simple way of calculating, assessing, and acutely deteriorating patient. And comparing is very easy for you to compare. You don't need to remember what was the systolic blood pressure or what was the heart rate 3 hours before. You just needed to know, okay, 3 hours before news was 0. Now the news is 5. Or the last 12 hours, the news is varying between 2 to 8. So you know this patient is actually having improving or deteriorating. It's a simple format of communication. And ISBAR is a structured way of handing over a patient or communicating about a patient. It's a very structured format. We will only talk about the relevant information, who you are, what you have done, what happened to the patient, and what is the news score. This is all the information you need. It actually can be done in 2 minutes. The whole process I said to you in the last 1.5 hours, once in practice, is only take 1 minute to 2 minutes. Do your observation, record it, chart, say your score, and escalate it to the relevant team, to the primary team, to the doctors, to the senior nurse, whoever your system allows you to escalate it to, or to the cardio-respiratory. Okay, so do we have any questions?
Thank you so much, Jasmin, for the brilliant presentation. I'm sure there's going to be some questions now. So in essence, EWS is a bit like a traffic light. If you think of, you know, green or white means it's all clear, patient is stable. Yellow meaning if the patient falls into yellow category, that means it's a warning alert. And red means you need to act immediately. So that's the time frame that you're looking at. And in terms of reporting it, there's a structural way, as Jasmin suggested: situation, background, assessment, and recommendations. So let's take some questions now. The first one is from Adinan. Adinan, can you talk? Can you unmute and talk, please? Adnan, can you talk?
Yes, sir. Yes, sir.
Okay, well, can you ask your question, please?
You can type the question if there is a problem with the network.
The next one is from Manju PR.
Can they type it in so you can get out?
Okay, Manju is not responding. Rini Tito. Rini, can you hear us? Can you unmute and ask your questions?
Probably they may not hear, or we may not hear, because there are too many people and everybody start speaking. It will be a lot of disturbances.
Okay.
Probably we may not hear it.
Maybe
some of you have not put your names. Unfortunately, there's someone called Galaxy A20, Galaxy 420. Okay, Monesh, do you have a question? Can you unmute and ask? Monesh AM?
Yes, sir.
Okay, what was your question, Monesh?
So you said that uh, the condition of the patient, sir,
Yes.
the respiratory rate, oxygen saturation,
Yeah.
but the blood investigation,
Mm-hmm.
there are more variables in blood investigation during a trauma or something, sir.
Yes.
How can we assess that, sir?
Okay. Can I answer to that?
Yes, yes.
Okay. What was his name again? Sorry.
Monesh.
Monesh,
Yes,
thank you for your question. This is very good. Okay. The purpose of EWS is, Monesh, is to times, and I understand trauma calls and cardiac arrest and all, they are all emergencies. And blood investigations are all your next level of management. Yeah. You don't, this is an acute response. You have a patient who now with head injury or trauma coming into you. What do we need to know is the first instant assessment. We need to understand how sick is this patient. I bet you take the blood will go and the result will come back in 2 hours, 30 minutes. That's a long time. EWS is the purpose of early warning scoring is to assess the patient in the first instant, immediately. Okay, then all other information you get, even to your chest X-ray, your CT scan, your MRI, is all the next level of assessment. You understand me? So you don't need, we need those secondary information later. This is the first primary level of assessment of a patient. As soon as the patient comes to your ED, emergency department, you did an observation and you saw your patient. Even if you have a patient who is bleeding, you know, they're hypotensive, they'll be tachycardic. It will always give you a score of 5. So it is like the first line of assessment. Okay, that is why we don't incorporate. They're all, and we don't need the next level of, that is the next level of management. This is the first primary assessment to understand everyone. Okay, I'm telling you, I'm an ED nurse, I'm telling you, I have a trauma patient who is here with the news of 8. Which alerts every other team or who understands, know that this patient is sick. And they come. Then comes your blood result, your chest X-ray, your CT scan, your MRI scan. That you take your management strategy. That is not your initial assessment. Our vital signs are our first level of assessment, right?
Okay.
I hope I answered to you. Yeah.
Thank you, Jasmin. Monesh, hope you got that answer. If you have any follow-up questions, kindly raise your hand again. There's quite a few people wanting to ask questions. Okay, Monesh, do you have a follow-up question?
Sir?
Monesh, do you have a follow-up question?
Yes, sir.
Okay, go on then.
So if I was wrong, please sorry. So that I have a case that is a diabetic patient and have blood pressure patient.
Yeah.
And he was normal and in a right leg he had a wound.
Yeah.
And he is under treatment. All of the vital signs are normal.
Yes.
When we admitted in the hospital, the WBCs are highly increased.
Mm-hmm.
The pus are in the blood vessels and it will be all over in the blood there are pus, sir.
Yes, sir.
But in appearance, the patient was good, sir.
Yes.
How can we identify the patient in a right way, sir?
Okay, Monesh. This EWS score is, so your patient is not actually acutely deteriorating, right? Your patient I can understand your patient's white cell count is high and patient but he is asymptomatic with it. He is not a patient who is actively deteriorating at that point, right?
Monesh, essentially.
Yes, ma'am. Yes, ma'am.
Yeah,
Monesh, essentially, the patient is chronically unwell and he is not currently acutely unwell at the moment. However, if you let that patient ooze, or if he continues to have a pus formation, obviously he's going to go into sepsis at some point. So, like Jasmin said at the beginning, every single patient will give a warning within the last 24 hours. So if you continue to if that patient continues to deteriorate for the next 24 hours, if you don't take any action, that patient is likely to go into sepsis. That patient is going to.
This is an ideal case what actually you are talking, because you've done your observation now and you know your patient is news is 0. And if you have done nothing about it, or you left him alone, you continue the management, he is on antibiotic, I suppose, or he's on fluids, whatever your management is, and you go back and done your observation after 6 hours, you now have seen if this patient is deteriorating, definitely you get a warning there, unless he sudden arrest. Yeah, there are some patients who go into sudden cardiac arrest.
Such patients usually they go into septicemia.
Absolutely.
Beginning observation. Very good observation.
Yeah, but only thing that you have to be cautious if the early warning score is 0, but he still is internally deteriorating. If you suspect that one, you have to look back his history. If he's immunocompromised, he won't be showing the signs either. The temperature won't be the first parameter because he's immunocompromised. So you have to look for the history also when you're looking for the early warning score.
Monesh, this is just a guideline. Essentially, you have to use your initiation as well. Like you mentioned, patient may have the underlying problems. There is a fairly obvious problem there, as you identified. However, your expert instinct comes in there, where you said this patient, although the vital signs are stable, this patient is still having problems. I do need to address it. But now you got enough time to address it.
Absolutely.
If you let that patient sink in, then that patient is going to become acutely unwell, and that's when you're going to get into trouble. So,
these sort of, sorry to interrupt you, Samir. These are the patients who actually stay okay. Given you the score of 0, he's everything clinically okay. But if he is beginning to be in, as the Holis are saying, onto the path of septicemia, you begin to get a warning. You will see after next 6 hours, if your antibiotic is not working, you will see his beginning to be tachycardic or hypotensive or hypothermic. We have cold sepsis too. Don't forget, we have, it is not, the sepsis is not alone with hypothermia. Hypothermia is also, it's very rare, but you have cold sepsis. Your patient may go into hypothermic sepsis, just because Rajendra was saying about neutropenic sepsis, that's what I'm saying about. We have cold sepsis too. They will give you eventually a warning. You will do your next set of ops, which will be news 2. After 10 hours, you would see the news 5 because he is going to be septic. What is the purpose of EWS? To keep a track. If the patient is okay, pus is coming, but news is 0, he is still in the line, he is stable. Don't forget, any patient who's coming to hospital is because they have some problem. Otherwise, they won't be coming to hospital, right? So that should be in your mind.
That's a fair point, Jasmin. That's a very good point.
Well,
sorry, there's a few questions here. Let's just be very short because of the time constraints.
Thippeswamy, just sorry to interrupt you. Before that, we need to post the post evaluation. So meanwhile, other students can fill that one.
Yeah, okay. You want to post it? Okay, we're going to do the post evaluation form. It's going to be on the chat box. Kindly follow the link on the chat box. You got 10 minutes to complete that while we are answering these questions. So watch out for the chat box link for post evaluation. And just to reiterate that so students who participated in that, who completes that post evaluation will only be able to get that participatory certificate. So please make sure that you all complete that post evaluation questionnaire. Okay, the next question is from Manju PR. If you are able to unmute, can you talk? Okay. Yeah, Manju, go on. All right. Okay. Sorry, Manju. I think there seems to be a problem. Anupam? Anupam, can you unmute and talk? Anupam, Galaxy A30.
Good afternoon, sir.
Hi, good afternoon.
Good afternoon, sir.
Go ahead.
Second year student, sir. So my question is, a man, some problem also be the on other disease, there also be is in the hospital admitted, then on drugs also be given, but day by day the drug also be attack the cardiac arrest. How to manage the situation, sir?
Anupam, do you speak Hindi?
Yes, sir.
Okay,
Sir,
हिंदी में बोलो.
हिंदी में बोलिएगा आप, हम लोग आपको ट्रांसलेट करेंगे, नो प्रॉब्लम.
हाँ सर, एक आदमी हॉस्पिटल में आता है कोई डिजीज को लिए, बट वो डिजीज को असिस्ट करना चाहिए. देन ऑल्सो बी देन वन ड्रग्स ऑल्सो बी गिव देन, बट वी आर डोंट नो द ड्रग्स इज द affected the man, and then by day the drugs also be affected your cardiac arrest this man. And so how to manage this situation and how to prevent the man for the cardiac arrest?
Okay.
Hello, sir.
Are you saying that if you administer a drug for a patient for some condition, that can affect the patient's heart condition? Is that what you're saying?
No, sir. The other disease, some other disease also be
It can
he or
risk.
she admit.
It's got risk factors. It can cause other symptoms. If you're given a drug for a cardiac condition, it can cause other diseases. Is that what your question is?
I think he is asking, I don't understand Hindi, I'm so sorry, but what I grabbed from what he was saying is, I think if a patient who was already on some drugs which, like which cardiac
drugs,
which can proceed to cardiac arrest, how would you prevent or how would you stop? I think this is what he's saying. Look, the way I can answer to you is, I forget your name, but the way I can answer to you is, it's so simple. Any patient who is under your care, whatever the drugs you are using, whatever the condition they get admitted, you are doing a set of observation. Your vital signs are the parameter warning for anything. They are the alarm. They are your signals of your body. This is a signal given to you. So you given certain, for a simple example, you given digoxin for your patient who is in AF. Digoxin have a side effect which they can take them to bradycardia. You give amiodarone. It will, if you don't monitor these patients, they go into bradycardic and they can arrest secondary to that. So what you do, whatever the drugs you do is you take a set of observation, because your doctors normally say if you're giving amiodarone, can you monitor the heart rate before you administer it? So you take a set of observation. Now, how do a patient go into arrest? This is a simple question, because your heart has to have some changes. Your body has to compromise. How do we know that? You don't need an expert consultant to understand this. You know, the body will show you some signal, which is through your heart rate, your blood pressure, your temperature, whatever. So you are measuring those core parameters. And you see there is a change. You respond to the change accordingly. You given the drug for that cardiac problem. Let's say it was an amiodarone. You monitor the heart rate now, and the heart rate is 50. After a couple of 10 minutes later, so you understand there's something happening. You monitor your heart rate. It become now 30. This patient is bradycardic. You either need a reversal or you need to pace this patient. So that is how you will prevent cardiac arrest. So what did you do here? You checked your observation again. This is why we say new score is important. The new score is the one. It tells you what is wrong, and you respond according to your change happened.
Yeah. Anupam, hope you got that message. Essentially, what Jasmin was
Yes, sir.
Anupam,
Yes,
essentially.
Sir. Thank you, sir. Thank you, ma'am.
Thank you. Okay.
No question is a wrong question. Okay, please don't feel. I really appreciate whatever you're asking. I know you're a second year student.
Essentially, what Jasmin was saying was, this is a primary assessment. Currently, you have to address bradycardia. The patient is having, you got digoxin example. So the patient is having bradycardia. You have to address the bradycardia first. Then you find out what caused bradycardia, and then you address it. So whether it's a medication, whether it's a illness, so that's a secondary assessment. So your immediate intervention should be to address the bradycardia and make sure the patient's heart rate is getting stable.
Yeah,
so that's
alert
what Jasmin
somebody
was,
because you identified there is a bradycardia. Let someone know. Your senior team or your medical team know. Okay, I gave this drug. Now my patient's heart rate is this. Or I gave this drug. My patient's heart rate is 140. Patient is an SVT. Address it to someone. Identified. Inform somebody.
That's where the ISBAR kicks in. Situation background. This patient has got a AF, history of AF, for example. This patient is on digoxin. I've just given the digoxin and this patient heart rate is now this. So they will get an idea, some idea of what could be the reason. So, okay, next question is Yashaswini. Can you unmute? Yashaswini. Just reminding others to please log in and complete the post evaluation form. Asked to, okay, Yashaswini.
Hello, sir. Good
Okay,
afternoon.
go ahead, Yashaswini. Good
So,
afternoon.
about, as ma'am said, news is not applicable for the patients like pregnant women, children, and the patient with spinal cord injury.
Yes.
I agree that children and pregnant women has the different range of vital signs varied, but why spinal cord injury patient is not included for news?
Okay. I don't know how much in depth you understand the spinal cord injuries, because spinal cord injury patients do they have a variable normalities, okay? Because they have vagal response, very quick vagal response. So some of their normalities are not as, because that's a constant damage, right? You have your, I don't know how to make it in a simple term. For an example, their vagal response to stimuli is different. They have an unpredictable values. I can't say, sometimes their heart rate can be fluctuating from 90 to 110, which could be normal to that particular patient. You understand that? It's not, we all know that 110 or 100 and above heart rate is tachycardia, but certain spinal cord injury patients, normality is different. So they survive with a heart rate of, it's like your COPD patients. We all know that the respiratory rate is 88 to 92 is normal to the COPD patient. The saturation of 88 to 92 is normal to that patient, because they don't need more than that. More than that of oxygenation is harmful to them. Same way, spinal cord injury patients have an individualized normalities, if that makes sense to you. Some of these patients, normal heart rate will run with 100 or 110. So we can't calculate. So in my EWS or in our EWS, that is tachycardic. And you don't want to call your doctors every time because he's tachycardic, because these patients run. I have seen patients who's with temperature, body temperature 39. That is their normal temperature for that patient. Especially if you have seen hypoxic brain injury patients, their normal body temperature, you have to accept that is their normality. You tell me what? I hope I answering to your point, because every spinal cord injury patients or hypoxic brain injury, certain patients have their own set normal body values. But what we are talking about is a general normal body values. So a patient with hypoxic brain injury with hypothermia or their normal body temperature hyperthermia of 39, I don't want to call the doctor every time saying that this patient is pyrexial, this patient is, and especially in intensive care unit, we see that a lot. Some of these patients, you can't bring down their temperature. Their normal temperature is 39. And I don't want to give paracetamol for that. I don't treat this patient as septic because their body is set to that. So that is why we exclude spinal cord injury patients from EWS. Because these patients, same like your dying patient, they will have always all the parameters is high. Same like your COPD patients. If I say, oh, saturation is 88 and COPD patient, it's okay. It's normal for them. That is what we want for them because they have hypercapnic drive in breathing. But for you, as whatever the girl name is, if someone tells your saturation is 88, I will worry because you are a normal human being with the normal parameters in your body, and 88 is abnormal to you. The spinal cord injury patients, they have individualized most of the time.
So essentially, Jasmin, am I right in saying that the patients with spinal cord injuries will have a modified early warning score that is being specified in their records, medical records?
Yes, they have their own pathways, we will say.
Yeah.
Accept the blood pressure of 90 for this patient as the normal. Or we will say, accept the heart rate of 130 on Mr. John, because he is a spinal cord injury. He normally runs with the heart rate of 130.
Okay.
It does
Right.
not compromise his blood pressure. It does
I
not
think
compromise his-
Jasmin is trying to ask, I think, why it is the parameters will be, not the parameters, vital signs are affected. I think she's asking more physiological question.
That is
So
the
that you have to go back to your college teachers. In one word, what happens in the spinal cord injuries, their autonomic nervous system, which controls the heart rate, temperature, respiration, all those systems will be affected because of the spinal cord injury. So what will happen, your body or patient's body automatically sets to the new setter. For example, if I changes my temperature, it will be changing according to the room temperature, everything. But where their body won't be able to respond to the changing environment. So what will happen is the body will go to the new set of mode, which won't be altered how it will alters in our system. So in that case, what happens if the patient with a spinal cord injury may have the blood pressure of 90/40, that may be the baseline forever for him.
Absolutely.
For a normal person, it can be early warning score of 3. But for that patient, that will be the normal. No matter what we give, if we give the medication, IV fluids, it won't come up. So that is the normal new baseline for that patient. So what will happen?
For him.
Yeah, new normal.
Right.
Yeah. So that won't change. So that is his new vital signs, normal vital signs for him.
That is why we specifically
sir.
mentioned we exclude this group of patients, because don't get alarmed. Because this patient, as we said, because they said their systolic is always, their heart rate normally be tachycardic. But you don't want to be alarmed because of that.
Jasmin, there's quite a few questions. I think you'll have to minimize. Please try and minimize your answer times, please, if you can. Anupam, can you unmute and answer questions, please? Ask your question.
Swami, I don't have much time. Maybe a couple of minutes more than I have to leave. It's only
Okay. Okay, we are happy to take the questions. Yeah, we are happy to take the questions.
There is one more Thippeswamy. Somebody called Infonix Hot 6 Pro.
Yeah.
No, ask them to introduce themselves first, please.
That's a good thing. Yeah.
Anupam, if you're online, can you please unmute and ask a question? No? Okay. Infonix, can you unmute and ask the question, please? And may I remind others to complete the evaluation, post-evaluation form while you're waiting?
Okay. Swami, I think I may need to leave now. And,
okay, thank you so much, Jasmin, once again.
Thank you so much.
I really appreciate it.
Rajendra.
Hello, ma'am.
Hello, ma'am. Thank you. Really, it's very informative. Thank you very much.
Sorry, sir.
Yes,
Anyway,
yes, yes.
Sorry, sir.
One thing, I am really grateful to your way of delivery. It's wonderful. So very nice it was.
Thank you
I
so
like
much,
your
sir.
ways. I am so grateful that you have dealt in such a that everybody they understood very well, including first year students. I'm so grateful to you.
Thank you so much, sir.
Excellent.
It's really, really nice to meet you all, and I'm really happy to spend my time with you. Yeah, I need to leave now.
I'm so grateful to you. Thank you very much.
Thank you, Jasmin.
Thank you, Jasmin. Thank you.
You have given a good color to this program.
Okay, thank you.
Thank you.
Bye.
It's so colorful. You are very smart also.
Anupam, sorry, someone was asking a question earlier. Sorry, go ahead, guys.
Hello, sir. I have one question. Now the COVID is the arise in our world, but one the COVID positive patient, he or she attacked the cardiac attack by the COVID.
Yes. So your question is that is the COVID can cause the heart attack? Am I right?
Yes, sir. Yes.
Hello.
Sir.
It's
Hello, sir. You hear me, sir?
Okay. Yes. So your question is that is the COVID can cause the heart attack? Am I right?
Yes, sir.
Rajendra, I can answer for that. It is said yes.
Yes. Okay. So it can cause, but not directly. What will happens? there is no proper evidence that it causes direct heart attack, but the virus attacks the myocardium of the heart. It causes the viral myocarditis. So that increases the troponin level. It mimics the heart attack when you read the blood, when you take the blood test. But when you take the ECG, there won't be any heart attack sign. But over the period of time, it can damage the heart muscles permanently. But there is no evidence. There is a huge research is going on at the moment in relation to that one.
Well, usually it causes a respiratory problem.
Yeah, cardiac problem also is causing, sir, because we have seen so many cases with viral myocarditis.
Yeah, later it leads to cardiac problem.
So,
yeah.
Okay, sir. Thank you, sir.
Okay, Anupam, do you want to ask question? Anupam?
Yes,
no.
sir.
Okay, go on, Anupam. Do you have a question? Anupam?
Sorry, sir. My network is very poor, sir. So I do not can't anything say, sir.
Can you hear me?
okay, we'll move on to next student, I think.
Okay, next one is Oppo F15. Oppo F15, what was the question? Oppo F15. You put your phone as your identity, not your name. Can you ask the question, please? Oppo, unmute now. Okay, go ahead.
Okay, so can we move on to the next?
Sir, Muninarayanappa sir.
Yeah, I can come in now.
Yes, sir.
I was going through the session. It was wonderful. I congratulate Jasmin and you, both of you. I'm really thrilled with the wonderful to see the session in this way. I am sure it will be able to generate attention and hold people's attention throughout the lecture and discussions. The format is wonderful. I really appreciate each one of you. That's what I want to say.
Thank you very much, sir. Thank you.
And one suggestion, when questions comes, please related to day's topic, people should focus. They may have hundreds of questions regarding nursing and other challenges in our nursing service. But questions should be always focused on day's topic. Otherwise, it goes on expanding. Okay.
Yes. Thank you.
I think we have to be. Thank you very much.
Thank you, sir.
Thank you, sir.
Right.
Well done. Keep it up.
Thank you, sir.
Thank you, sir. Thanks.
Right. Infonix Hot 6 Pro. Those who are on, who have, can I suggest that whenever you guys log in next time, all the students, can you please put your name instead of your phone name? It will be nice to address you with your names. If I could kindly request you to log, just edit your names, display names, and make sure that you put your name or a college name and your college on the display. That would be really helpful. Okay. Any questions? Rajendra, how are we doing with the post evaluation?
Getting the response. 1 second. One second. So we got 101 response.
Okay, Avinash. 1 second, there is someone called Avinash. Right.
I think Swami,
okay,
you can close
yes,
the answer now. Right.
Okay. I think we come to the end of the session. Thank you all so much for your participation, and hope you did enjoy the session. I look forward to seeing you for the next session, which is on the 19th of December. Muni Narayanappa sir, if you're still on the line.
I the panelist, I think, he need to turn on his video.
Yeah, my video, because I am eating food.
Okay, sir.
Sorry, continue, sir.
Okay, no worries, sir.
I know my video is not coming well.
Okay, sir. It's okay, sir. It's okay, sir.
Yeah. 19th, I know we have to have next session.
Okay.
So
next.
Please be in touch. I will do the required things. Whatever
okay,
is requirement is there.
Those who are online, just to let you know that the next session will be on the sepsis management, which is on the 19th of December between 11:30 to 1:30 India time. And we will share the event registration and pre-course evaluation forms, pre-course work, and shortly, along with the login details for the session. Thank you all so much, and have a good weekend.
Before you finish, I think, Munanappa sir, are we using the MS Team or the Zoom from your college?
I think we'll go for Zoom here. I will talk to talked to an IT manager for especially for this month. We'll subscribe. What should be the number, maximum number?
Sir, can we interact that separately?
Yeah,
no, for the students to download, if they're using the MS Team, so that they can download the MS Team now.
Yeah. I think we will talk it later. Okay.
Yes.
Monday, shall we finalize this?
Yes, sir. Monday
or Tuesday. Okay.
Okay, sir. Thank you.
Well,
Thank you,
sir. Fine.